So in this video, we're going to discuss patella tendonitis, patella tendinopathy, and in general, patella femoral pain syndrome. In all circumstances, these are generally classified as pain in the tip of the knee here, in the kneecap, and often in the quad. Now, generally speaking, the diagnosis is that there's been an inflammatory process that's happened in the knee. Now, interestingly, MRI scans and ultrasound scans often find there's some type of inflammation in the tendon, even with people without pain whatsoever. So what we draw from that is it's actually not uncommon that people tend to have a little bit of inflammation, low grade background inflammation in that area, even without pain at all. So some type of wear and tear is expected in that structure just because the amount of load in that structure undertakes all of the time. So imaging just to confirm the diagnosis of patella femoral pain syndrome often isn't that diagnostic, because we would expect that there'd be some low grade wear and tear in those areas, even with people without any pain whatsoever. The treatment for patella femoral pain syndrome is actually quite simple, and usually it's just about understanding actually how all of this started. Now, generally speaking, what we have is we have four muscles in the front of the thigh here called your quadricep. Now, those four muscles, much like guy ropes on a tent, actually have to pull all at one point, and they come down to one point here on the patella and onto the patella tendon. Now, what happens is if there's some dysfunction in the quad where some muscles are pulling more than the others, it causes a tracking issue of the kneecap, and the kneecap is running in, is embedded within the tendon and actually helps the knee flex and extend. And if all of the muscles in the front of the thigh aren't pulling evenly, then we tend to find that causes some irritation and inflammation. And irritation and inflammation built up over time will start to give us the appearance of pain in the tendon of the patella. So the treatment for that actually is quite simple. So number one, the first thing we need to do is just make sure that there's nothing more sinister going on, that we're just dealing with a simple biomechanical problem whereby the tendon has become a little bit irritated, a little bit overworked in some sense, and inflamed because the tracking of the muscles pulling at the same time in the quad hasn't been working so well. And so from the perspective of how we view things and the lens we view things in clinic, what we need to do is fire up all the muscles in the front of the thigh to get them working evenly. At the same time, we need to reduce the abundance of inflammation so you don't actually feel so much pain. And at that time, we also need to check that the hip and the ankle are also doing a good job, because if the biomechanics is altered in the joint below or perhaps the joint above, it's going to affect the biomechanics of the knee, putting extra strain on the knee. But having checked that the hips and the ankle and the foot are doing really, really well, the front of the thigh is doing really well, all that really now remains is actually providing good, strong, solid advice as to how frequently and how often we can return to activity. And therein lies the bit of the problem, because when we've had a tendon problem for a long period of time, maybe you've had the problem 3 to 6 months, then there will be, as we've mentioned, some structural changes. And so now what's really, really important is, as things are starting to come online and things are working better, we don't want to overload the tendon as it's becoming stronger. And in this point, we want to think of the analogy of putting 13 amps of current through a 3 amp fuse. You don't want to overload the tendon and actually cause another acute flare-up. So the way that we tackle that in clinic is we get you to do some exercises and see whether the exercises themselves cause any weakness to appear in the front of the thigh. If that happens, then generally that's suggestive that the level of exercise in volume, intensity, or loading might be a bit much. Once we figure out the maximum you can do, we tend to titrate underneath that by around about 30% in order that you can safely progress through your exercises and actually continue to strengthen the tendon, avoiding a future flare-up.